Hey guys, okay, so this is the review on esophageal tumors, esophageal cancer, and it is also in chapter 54 of our book. It's actually, I think, the last disease in this chapter that we went over. So, all right, for these patients, we want to assess them for history of risk factors. The two most common risk factors are smoking and obesity. We also want to ask if they have GERD, assess them for GERD, Barrett's esophagus. That's that pre-malignant tissue that builds up in the esophagus, the columnar epithelial tissue. Also, malnutrition, genetic predisposition, and excessive alcohol intake. Actually, it's a lot more common in men too. So, this is the disease. I have a friend that went through this, and so I talked about that in class a little bit. But so, difficulty swallowing is the most common symptom. So, if you have patients that have dysphagia, definitely ask them about certain things, such as if they've had changes in appetite, changes in taste, if they eat a lot of pickled or smoked foods. You want to ask if they have painful swallowing, adenophagia. I'm not sure how everybody pronounces that, but it's Odynophphaga. And then also, if they have regurgitation, check them for halitosis. And if they've had vomiting, chronic hiccups, changes in bowel habits, if they've lost their appetite, if they have anorexia, and then also if they've had a weight loss more than 20 pounds in a short period of time. It is a silent disease as well, so by the time there's some symptoms, there's usually extensive damage. So, for example, by the time my friend was diagnosed, his entire esophagus was pretty damaged. So, the psychosocial issues with this, you're really going to need to look at anxiety and then the loss of pleasure of food. Also, mealtime stress, social aspects of eating out, and then they're at an aspiration risk, and then also financial stress. This operation is because the only way to treat this is with surgery, and it is astronomical because they have to have so much post-op care, which I'll talk about in a little bit. For diagnostics, of course, they can do the barium swallow with fluoroscopy. They can also do the esophageal ultrasound with fine needle aspiration, the EUS. I think we watched a video on that. If we didn't, I'm sure there's one on YouTube. Basically, it's where they take an ultrasound probe that has a needle inside the probe, and then there's a little camera in there as well, and they can aspirate the tumor and check it. They can also do the EGD with biopsy and then PET scan. So those are some ways that we can take a peek at them. So our nursing diagnosis for this is going to be the biggest one is going to be risk for aspiration, just because there's so many respiratory complications that are going to come up with any kind of esophageal surgery. They also have a risk for malnutrition and risk of infection due to immunosuppression and surgery. So our nursing interventions in particular are going to be maintaining or improving their nutrition status, reducing the effects of treatment, especially with this is a big surgery. So our friend that had really severe weight loss, I mean, like a lot of weight loss, and a lot of complications too with getting care, honestly, um, especially post-operatively for his NG tube or his G tube, and also the nutrition and enteral feedings, and it was really rough. So we want to keep the patient as comfortable as possible, keep them upright after and during meals, and then teach them the chin tuck technique for swallowing. So they need to do a little chin tuck and while they're eating, and then also give them liquid nutrition like Boost or any protein shake kind of deal, because that's honestly, sorry, they're going to gradually increase to solid food, so they're going to need some liquid nutrition for a while. Also, check for pocketing of food after they swallow it. For these patients, it's really important that they see a speech therapist, and learn how to swallow again, because we're basically, with this treatment, with the surgery, they're taking out the esophagus and attaching the stomach to the like back of your tongue. So that's a pretty invasive surgery. And they need to have nutrition therapy with a registered dietitian, and then they'll do swallowing therapy with their speech therapist, and then they'll do feeding therapy with their occupational therapist. And I explained this in the musculoskeletal videos, which I'll probably redo, but for the Pia, no, sorry, my cat is scratching my couch. So for OT, the main concern or main point of focus for an OT is going to be ADLs and their fine motor movements, so eating for sure. And then also with the surgery, they also have chemo and radiation. They can do targeted therapy with photodynamic therapy. Those are the light sensitive meds that collect in the cancer cells so that they can be removed, if they feel like they don't have to take out the entire esophagus. They also can do esophageal dilation. There's a perforation risk with that. Again, we discussed that in the last video with the treatment for the hiatal hernias. But there's also endoscopic therapy that they can do as well. But I think the main one that they want us to know about in particular for our purposes is the esophageectomy. And during that, the surgeon removes a portion of the esophagus that contains the tumor, along with a portion of the upper part of the stomach, and then the lymph nodes as well, depending on how far the cancer is spread or metastasized. And the remaining esophagus is connected to the stomach. And our highest priority is going to be respiratory care, especially for the first 16 to 24 hours, because they will be on a ventilator the first 16 to 24 hours. That needs to be explained to the patient before the surgery, so that's going to be a big part of our teaching. Also, risk for pulmonary complications such as pneumonia and atelectasis. So we need to teach them deep breathing and coughing every 1 to 2 hours post-op, and then assess for decreased breath sounds and shortness of breath every 1 to 2 hours as well. So we need to keep them in the high Fowler's or semi-Fowler's position to prevent reflux, and they're most likely going to be on an antacid as well. We need to also monitor for fluid volume overload. So we're going to be listening when we auscultate for crackles. And then we need to check for edema and increased jugular venous pressure. Again, we can just see the pulsating here on their neck. And then we need to also do cardiac monitoring for every 2 hours. So you're going to monitor mainly for AFib. And then we're going to watch for symptoms of mediastinitis, so inflammation of the mediastinum. And then fever is the first symptom of that, and then also fluid accumulation, inflammation, and then shock. And this is something we need to immediately report to the surgeon and rapid response team because this is fatal. So for the pre-op teaching, we really want to teach the patient about the number of incisions and drains that will be placed, as well as placement of the G-tube. That can be really intimidating for some patients, so I think we need to take extra care to let them know that this is a temporary situation, and also that it's important that they have a strong support system. So it's really good if you can loop in family and friends into at least their closest loved ones into the teaching. But if they allow it, if they want it, with them there, hopefully they do. But we also need to let them know there's a possibility of having chest tube and IV infusions. Also, we need to teach them about regular turning, coughing, and chest physiotherapy, as well as deep breathing, and then post-op respiratory care, like the ventilator. And after that, they'll be on using the spirometer, and then wound management as well. For their post-op teaching, they are going to be on 6 to 8 small meals a day, and then oral hygiene every 2 to 4 hours. They should not have any bloody drainage after the first day. If they have bloody drainage after the first day, then that is a sign of internal bleeding. So, FYI, that is super important. They should have fluids between meals, not with meals. This will prevent diarrhea for them. And then they need to avoid large crowds, sick people, and then also immediately report any symptoms of respiratory infection, mainly because they're going to be immunocompromised from the radiation chemo treatments. And another really important thing, I believe this is in a box on the box. It's a yellow box on page 1097, and it is basically to teach the family about signs of airway obstruction, pneumonia, and food aspiration. So definitely want to teach family that. And then also we are not, absolutely never, ever, ever to irrigate or reposition an NG tube in these patients without direct orders from the physician. So I know irrigation is something that we'll do with, I think, most of our other patients. So, but with these patients, you cannot do it unless the physician has specifically ordered it. So I think that is pretty much it for esophageal tumors, esophageal cancer. It is relatively rare in general. And then things that are preventative for patients, really tell them no smoking. They need to avoid drinking really hot liquids, and they need to drink alcohol in moderation and manage their reflux. So this would be important to teach your GERD patients, actually, because they can get the Barrett's uh, thing going on if they don't take care of their GERD symptoms. So they need to maintain a healthy weight, and it's a lot for someone to go through, to learn how to swallow, eat food, not really be around a lot of people because they're immune compromised from the chemo and or radiation, and then also learning how to manage a G tube, and that's pretty rough. So take good care of these patients, and if you guys have any questions, let me know. I can also talk to my good friend that had this, and he'd be happy to share a little bit of his story probably. So anyway, I think that's about it. I will hopefully see you guys soon. I miss everybody. So damn COVID-19. But take care of yourselves. Thanks, guys. Bye.